All right, guys, well, welcome to this pharmacology drug class review on the direct oral anticoagulants, factor Xa inhibitors. In this session, I'm going to explain why this subclass of DOACs matter. I'm going to make it easy to understand, clinically relevant, and if applicable, can even prepare you for your exams. All right, DOACs like Apixaban and Rivaroxaban represent treatment options in the management of DVT, PE, but also serve as an alternative to the historically used Warfarin for the prevention of cardioembolic stroke in patients with atrial fibrillation. So you're going to encounter them repeatedly in real-world clinical practice, but also on exams. Hey guys, I'm Dr. Busti, and thanks for joining me on This Is Why, a show dedicated to helping all of us as healthcare professionals understand the why behind pharmacology and the drugs that we use every day. When you understand the why, the how becomes easier because that mechanism of action starts to make sense and predicts the therapeutic effect that we're looking for. Also the side effects, contraindications, monitoring parameters, and counseling points that we make to our patients. As with all the drug classes that I do, we cover core content, and that includes we cover what agents make up this class, what are the common, not every single, but what are the common indications and uses? What's the net benefit? Why would I pick this drug class or even think about it in the context of other drug classes that I might have available for myself to use? Then we're going to dive a little bit deeper into the pharmacology, the mechanisms, some of the pharmacokinetic dynamic differences that make them unique of one agent over another. And then we'll bridge over into that clinical knowledge, some application, and then wrap it all up, okay? So let's first start off and address what agents are we talking about when we say oral factor Xa inhibitors, or part of our class of the DOACs, okay? So those are our direct oral anticoagulants. So we have Apixaban, Edoxaban, which is less commonly used. I've never even seen Edoxaban. I'm not saying no one uses it. I'm just saying that I don't see it very commonly in everyday practice in the patients I take care of. And then Rivaroxaban being the other one, okay? Now, we do have a parenteral formulation of a factor Xa inhibitor, and that's Fondaparinux. Now, I tend to cover that in the Heparins lecture, okay? We cover heparin, unfractionated heparin, low molecular weight heparin, and what some people call as a ultra low molecular weight heparin, Fondaparinux, or a direct Xa inhibitor that is parenterally administered. And it matters to bring this point up, guys, because the mechanism of action is actually different from the DOACs. They're all direct Xa inhibitors, but they're not the same mechanism, and people get that confused a lot, especially for exams. But we're going to clear that up for you today. All right, what I've tried to provide you here is a table, and in this table is a summary of all the different anticoagulants that kind of make up that overall category. So we have warfarin, unfractionated heparin, low molecular weight heparin, our direct Xa inhibitors, and then our direct thrombin inhibitors. So for those of you that are joining us on our podcast channels, you can access this for free at thisiswhy.health or go to YouTube, obviously, and you can see the video. Again, for those of you that want to download this, use it for studying, share it with your friends. If you're a preceptor or faculty, feel free to use it in your lectures. That's why we designed it, okay? Now, the way it's organized in columns is each column represents one of those subclasses of the anticoagulant category. And so right here, over towards the right side, you see that we have our direct Xa inhibitors. And I put Fondaparinux in there again, not because it's a DOAC, but because it is a factor Xa or direct Xa inhibitor. So Fondaparinux here has this letter F, right? And so it's one of our subcutaneously administered medications. We don't use it IV. I mean, you could theoretically give it to somebody IV, but it's not recommended, and nor is it, there's no dosing indications for doing that. It's kind of like enoxaparin. Enoxaparin is most commonly administered subcutaneously, but can be given IV push in STEMI. But the F is just a abbreviation for that drug, whereas AER that you see listed here represents Apixaban, Edoxaban, Rivaroxaban, okay? Those are administered by mouth, and those are your DOACs. The next thing that you see in each row represents some of those other characteristics, right? Things like mechanism, does it need to be titrated? And you see in this particular drug class, there is a plus or minus. Some drugs have a period of a higher dosing for a period of a few weeks and then it drops down. Some don't, okay? Onset of action, it's pretty actually acute. And the reason I point that out is because we're typically comparing these drugs to warfarin, which we know has a delayed onset because it impacts the functional activation of clotting factors 2, 7, 9, and 10, only the new ones that are being formed. And so the old clotting factors that have varying half-lives of various days sometimes, they're going to take a while for them to go away. And so it's not an acute onset of therapeutic anticoagulation that we're getting with warfarin, whereas this drug class does. And so the reason that matters is that if you're treating an acute thrombotic event like acute PE, you can theoretically use these drugs, and we do send patients home from like in the emergency department as long as they're hemodynamically stable and are able to get the medications. We send them home on treatment. We don't admit anymore for bridge therapies with warfarin and unfractionated heparin drips. Now, we still have to do that sometimes in certain patients, but most of the time, and nowadays, if they're stable, we can consider sending them home. And so that acute onset of therapeutic benefit, especially if you're going to be compliant, is a good thing there, okay? Duration of action, about 24 hours once you reach steady state. The reason that matters is because, well, if you start to bleed, you don't want it to last forever, right? Whereas, you know, some of these drugs, the impact can last, Coumadin's effect can last several days. It's not affected primarily by food. There's really no monitoring of it here, okay? Renal dose adjustments, yes. Drug interactions, yes, can be impacted, especially with the DOACs, where cytochrome P453A4 shows up. I'm going to cover this a little bit more in detail, but again, I wanted you to see that this table is summarizing those things and comparing them to the other drug classes, because again, those are the nuances of why you pick one agent over another. Now, there used to be an antidote available specifically for these agents. That drug is now gone. So PCC, activated PCC, is our main antidote at this time. Okay, so that represents primarily the overview of the agents. And I just really wanted to give you a brief side-by-side comparison in that table. I think that table helps me to keep it in focus again, of why do I pick one agent over another. Now let's move on to the indications and common uses in everyday clinical practice. Now, from the acute care side, okay, and it says acute chronic care because we use them in both. So it doesn't matter where you practice, you're going to see these drugs, okay? So I mentioned DBT and PE, especially in the acute, so you can use it for treatment, but you can also use these agents for prophylaxis, okay, as it relates to Afib, okay, and that prevention of cardioembolic stroke, assuming the patient doesn't have a high risk for bleeding. So this is where we would consider the CHA₂DS₂-VASc scores, we would consider HAS-BLED, risk stratification tools to kind of give us an idea, is the overall net benefit of using these drugs better than the risk of bleeding, okay? And so those tools are available to help guide you in those decisions. But these are the main reasons, and even in the acute side, where we can send patients home from the emergency department on therapy and not have to admit them to the hospital. All right, so let's now move to what we would consider the net benefit of this drug class. Again, why do you give it consideration? And I hopefully have already started to allude to what some of that looks like. Okay, so the oral agents, okay, factor Xa inhibitors have antithrombotic therapeutic benefits that are as good as warfarin. Remember, we just need some equivalency here, because the standard of care historically was warfarin, vitamin K antagonist, known as warfarin. But it's got all kinds of problems with it, right? Drug interactions, it takes a while for it to get to therapeutic effects. You got these crazy convoluted dosing regimens that patients have to go through. And then you got to monitor them and constantly get stuck and blood samples all the time to make sure that you're not over anticoagulating or you're not under anticoagulating them. It's just a mess to try to use that drug sometimes. I mean, I grew up on that. I had to work in actually a Coumadin clinic, right, where that's all you did, literally, is talk to patients all day long about Coumadin and constantly measuring their INRs. So when these drugs evolved, it was huge, okay? And out of the DOACs, there are other subclasses like the direct thrombin inhibitor, dabigatran is another DOAC. But this drug class in particular has really blossomed and helped us a lot in everyday clinical practice. So we have at least good of activity to Warfarin with Rivaroxaban, superior to with Apixaban, less routine monitoring, no drug interactions, but, I'm sorry, I didn't say no drug interactions, I didn't mean that. There are drug interactions that are relevant, but at least we understand them and it's not plagued with all the other stuff that warfarin comes with, okay? All right, and this drug class makes up the majority of the DOACs. Okay, now we're going to move into the pharmacology. Okay, I've already kind of started to dive into this, but this is where we're going to kind of get into some mechanisms, what makes one agent similar and different over another, okay? All right, so first things first, this is the normal, okay? So for those of you that need a review on the coagulation cascade, please see my lecture on that. I'm not going to spend time diving into every nuance in detail. However, the coagulation cascade is important, made up of two main pathways. The intrinsic pathway, which is things like factors 11, or 12, 11, 9, and 10, okay? And then there's the extrinsic pathway, which is most commonly associated from traumatic injuries to the vessel wall or something, again, from surgery, trauma, atherosclerotic plaques, those kind of things. But they converge and they merge together at factor 10A. And that's important because that's the target, factor 10A or direct 10A inhibitors, okay? Once 10A gets activated, that's the very thing that converts prothrombin to thrombin, and thrombin then drives that fibrin that primarily forms a clot or a thrombus in the venous system. So DVTs, PEs, the pooling of blood in the atrium from Afib that can cause a cardioembolic stroke. But please do not forget the presence of platelets. All clots or thrombi are made up of more than one thing. You've got red blood cells, you've got fibrin, you've got platelets, all of that mixed together. Now they vary in their concentrations and distributions based on the type or where the origin of the clot came from. So most of these indications that we talked about are venous thromboembolic events that we're trying to protect. And so drugs that interrupt the coagulation cascade have a primary benefit in venous thromboembolic formations. Whereas arterial thrombus, like an atherosclerotic plaque rupture, those are predominantly made up of platelets. That doesn't mean there's no fibrin there. There's both. Okay, so that's why even antiplatelet drugs can have some therapeutic benefits. Not as good as an anticoagulant by any means, not equivalent at all. But antiplatelet drugs can protect patients from even some venous thromboembolic events. Now, Fondaparinux, which I mentioned was, remember, that is one of our parenteral direct or factor 10A inhibitors. It requires, listen guys, it requires the presence of antithrombin to work. Without it, it does nothing really of anything meaningful, right? Antithrombin is present in our bodies and is a normal endogenous anticoagulant. It's just not a great one. When Fondaparinux binds to it, it changes its conformational shape and makes it a really good one, okay? That's different than the DOACs. The DOACs directly inhibit 10A without the need for antithrombin. And that's what's really being highlighted here is the utilization of an antithrombin complex to inhibit the clotting factor. That mechanistic difference in its pharmacology, which is a pharmacodynamic effect, right, is one of the big areas of confusion that students and early people in training miss when it comes to understanding the pharmacology. Okay? The reason it matters is because if you have somebody with antithrombin deficiency, this drug Fondaparinux isn't going to work, but the other DOACs will work fine, okay, because you don't need it. All right. Now, is there a difference in those that are administered by mouth versus those that are administered parenterally? Well, that goes back to structures. Yeah, your favorite, medicinal chemistry. I know you're just excited. No one needs to memorize these things. It just gives you the appreciation of the why. So small molecules, like over on the left side of the screen, Apixaban, Edoxaban, Rivaroxaban, are more likely to get transported across cell membranes and get absorbed. Okay, big, huge, bulky molecules, right? Like you see on Fondaparinux, they have to bypass the GI tract. The acid destroys them, disrupts them, all this kind of stuff, or they're too big to fit through a transporter or through the cell membrane. So they have terrible bioavailability, so we have to administer them parenterally to bypass the gastrointestinal tract. So I only show you the basic structures here for that purpose, and that's it. Okay, I just wanted you to have that kind of that visual in your mind. You do not need to memorize these things. Okay, now moving on to some other pharmacology principles, pharmacokinetic considerations. I talked about the acute provision of antithrombotic effects with these drugs. That's a benefit, guys. We don't have to wait. Within 2 hours, we can get adequate plasma concentrations that are comparable to the initiation of parenteral heparin. So that rapid, reliable onset allows patients to be discharged from the hospital sooner, or even from the emergency department, assuming they can get their medications filled, right? So that's an access issue then that we sometimes have with our patients, okay? Now, Apixaban, Rivaroxaban are the classic ones used, and that's why I was saying earlier it's the most common one used, because the problem with Edoxaban is, especially the way it was studied, is that you have to be on it for 5 days with a bridge therapy with another anticoagulant that's parenterally administered, most commonly a low molecular weight heparin, which makes it less than ideal. Now, the half-lives are shorter than that of the effect of warfarin. Okay, so that is important if you start bleeding. Right? So we do have some options for reversing both of these drugs. We've lost one of the agents that used to reverse them that's no longer made. But PCC will still reverse that at some level, right? And warfarin has its also reversal agent as well. Okay, vitamin K and PCC, things we can use. Now, the problem though with this effect is that with it being a little bit shorter compared to warfarin is that you have to be compliant. So if you miss doses or you're non-compliant, the risk of stroke from cardioembolic or DVT-PE is high, especially in patients with hypercoagulable disorders. I've seen that. I've had patients just most recently miss literally 2 doses and get a DVT. All right. So we try not to miss those things or neglect that. Okay. And so these half-lives of these drugs are just really important for you to kind of have a framework that they offer that benefit, and they aren't going to stick around forever, but requires compliance. Now, as it relates to elimination, there is a phase 1 pathway of elimination that these drugs go down. That is our cytochrome P453A4 primarily. Well, and as I said earlier, there's some risk of drug interactions. Now, not as bad as warfarin that goes through 2C9 as well. These drugs don't do that. They're especially 3A4 substrates, okay? They are also eliminated by the efflux cell membrane transporter P-glycoprotein. That becomes very important because drugs that inhibit 3A4 a lot of times will also inhibit P-glycoprotein. So the risk of drug interactions is still relevant, even though these are good comparative agents and alternatives to warfarin. So you still have issues with that part. Now, Apixaban, Rivaroxaban also uses BCRP, which is another efflux cell membrane transporter for elimination. And then Edoxaban only primarily uses P-glycoprotein. Those are just some nuances. Now, renal dosing. I mentioned that on the table in the summary. It's a yes. Especially, interestingly, with Edoxaban. Again, it's just weird. This drug just has issues, in my opinion, which is, again, one of the reasons we don't see it. But when the creatinine clearance is really high or very low, the extremes, we actually are recommended to avoid it because of unreliable anticoagulation. So not only you have bridge therapies in the acute, but you have these issues in the extremes of renal function that don't fully make sense. Rivaroxaban does have some renal dose limitations, especially when you get a creatinine clearance less than 50, and then of course when it gets below 15, we're going to avoid that. All right, now we are going to pivot and move into this clinical application. So we've covered like a lot of that core knowledge. Sometimes you have to memorize it. Hopefully, as you memorize it and understand the why we use and pick these drugs, and then you understand the indications, it starts to help this phase to become a little bit easier, but we've got to get to the clinical application and knowledge that help us when we start to use these, because not all drugs are created equal, right? While these drugs are good and they're DOACs, that doesn't mean you use them in everybody, okay? So for example, in this case, as we go into mechanical heart valves, which, maybe they are less common than they were in the past, but I had a patient just last week in the emergency department who had a mechanical heart valve that was 30 years going. 30 years. So that patient was on Warfarin therapy, okay, for that reason. So we need to avoid these until more information comes out. Unfortunately, that is a limitation to it. And so that's why we can't just dismiss Warfarin completely. There are still situations and scenarios where that is the case. Apixaban, in patients who are using it for non-valvular AFib, again, non-valvular AFib is a term that is kind of the way it was originally approved. That terminology is not necessarily used in some of the guidelines. But these patients receive a dose, reduced dose of twice daily if they have at least 2 of the following. So older patients over the age of 80 years old are at higher risk for bleeding. Many times they're on other drugs, so the drug interaction risk is high. Remember, their renal function is going down. You see that listed here as another factor. Doesn't take much to get to that point. And then if you're low body weight, so less than or equal to 60 kilograms, then you need to use a lower dosing regimen to reduce the risk of bleeding. And once the creatinine clearance gets less than 25, or you're on hemodialysis, then we still have that concern, again, the risk of bleeding. So you've seen that kind of theme over and over again with renal in this drug class. We have drug interactions with this drug class and some nuances that are important. So this one is just that reminder of Edoxaban and dosing considerations, especially as it relates to bridge therapies, okay? And so you can't just use this by itself. You have to co-administer it with a parenterally administered anticoagulant. Most commonly, that is a low molecular weight heparin with Edoxaban, okay, with Edoxaban. Now, we mentioned before that compliance is important. So, man, it's got a lot of good things, but man, you got to be really compliant. It's less forgiving, right? We know as humans, we all have issues. We all make mistakes. No one's perfect. But premature discontinuation can clearly increase the risk of thrombotic events. And so you may have to transition that patient, especially if they're going for a surgical procedure or something. Sometimes we may have to even transition them or counsel them extensively when to stop it, depending on what kind of underlying reasons that they're being, on the medication. Now, epidural spinal hematomas are same risk as patients, like with Lovenox, enoxaparin, low molecular weight heparins, heparin molecules. We have the same warning here, where if there was enough bleeding around there, it could theoretically compress the spinal cord and cause some paralysis. And then lastly down here is that patients who have antiphospholipid syndrome, especially triple positive, those patients should be anticoagulated with warfarin. So we have the mechanical heart valves, but we also have patients with antiphospholipid syndrome. Those patients have very erratic even INRs. That's very difficult to figure out where they're at in their anticoagulation, even on warfarin. And so the standard of care is just that we use warfarin in that situation, but it has still got its issues and some problems. Now, patients who have undergone certain surgeries, these are DOACs. They're direct oral. That means we're administering them by mouth. So we're assuming, based on the pharmacokinetics and dynamic profiles of these drugs, those were largely studied in patients with a stomach with normal anatomy. Patients with bariatric surgery, there can clearly be a reduction in the absorption of these agents. And then of course, we have these issues with Edoxaban with the extremes of renal function that influences that we may not need to use that. All right. Bleeding, well, that's no surprise. All anticoagulants are going to increase the risk of bleeding, but the thing that we want to go think about, especially in AFib, is what is that risk of bleeding? Does that risk exceed the therapeutic benefit, so that the net ROI, if you will, is a positive, right? So that's why we use the CHA₂DS₂-VASc score, and we use things like HAS-BLED scores in patients with AFib, because this is relevant. So bleeding, we need to look for common things. So epistaxis, right, that's nosebleeds. That's going to happen, especially if you pick your nose, so don't pick it, right? If you rub it too hard, bump into something, you can bleed. I mean, the nose is highly vascularized, and I can't tell you how many patients panic when they start to bleed from their nose, or cut their scalp. They just bleed like steam. And so compression, just like everything else, it usually stops it, but they'll bleed a lot, right? Hemoptysis, then you're actually coughing up blood, blood in the stools. Certainly if it's dark, that would be melena or melanolic looking stools, like black tarry stools. That would be concerning. Tea-colored urine, right? That urine that's not dark, it almost looks like a patient with rhabdomyolysis, if you've ever seen that. Man, that urine is dark. Certainly if it's bright red blood, then that's obvious, right? Increased risk of bruising. People can bump into something just like on warfarin, and then 2 days later they have this massive bruise there. As long as it's not an expanding hematoma, there's nothing really to do, okay? But certain things like menstrual cycles where bleeding can be worsened. If they have an injury that involves the knee, they can get pretty significant swelling from basically a heme arthrosis, blood in the joint space. All that can cause patients to have decreased quality of life. Now, if you're slowly leaking blood over time, okay, small GI bleed essentially, you got polyps or colon cancer that's undiagnosed and you're just bleeding, you're going to start getting weak, tired. These patients may present with vague symptoms. I don't feel right, lightheaded, dizziness. That's why we're going to get CBC and look and trend it. This is where a medication use evaluation becomes important when you're working up somebody who presents with that symptom, because they may not be putting those two things together. Now, I mentioned reversal. Okay, what do you do when you start bleeding and maybe that bleeding is life-threatening? Okay, so PCC is the thing that more rapidly can convert these in acute major bleeds, those typically requiring more emergent surgical interventions, okay, or their INRs are very super therapeutic, i.e. they're typically above 5 or more, probably closer to 10, where we get really worried about it. And so there are fixed dose regimens that can help low fixed dose regimens that can help reduce the risk of thrombosis, because you're reversing something, well, you can tip the scale the other direction, right? So these agents can increase the risk of bleeding. These reversal agents can increase the risk of thrombosis, and you already have a patient scenario with the risk of thrombosis already present. Andexanet Alfa, again, is now off the market. The company is no longer making it, unfortunately. Really wasn't as valuable as we thought it would be. It was nice to have around. It made us feel comfortable a little bit in the background. Now, what do we do from a monitoring standpoint? Well, if bleeding is the primary risk, then a CBC is going to help us to assess that, monitoring the trends of hemoglobin and the hematocrit. We're not looking for the platelets. The risk of hit is not here in this drug class. In fact, even with Fondaparinux, the risk is extremely low, and some groups and some people actually use the Fondaparinux as a treatment in patients with hit because of that. So it's not binding to platelet factor 4. It's not really causing thrombocytopenia. It's really the risk of bleeding, right? We're not monitoring PT-INR like with Warfarin. There's no need to monitor PTT. It doesn't help us, okay? So you're not monitoring for this. What about CMP or BMP, comprehensive metabolic profile or a basic metabolic profile? Well, what are you getting out of those two? Mainly, it's the renal function. So you've already seen a couple of the extremes, like with Edoxaban, Rivaroxaban, and these drugs where we have to be careful with their use in patients with typically impaired renal function, but with like Edoxaban, where it was working too good, right? Liver enzymes, liver function tests, why that one? Well, remember, clotting factors are made in the liver. They're synthesized there, and they then have to get functionally activated for them to work, right? And there's a number of things that turn on those activations of those clotting factors, but they've got to be functionally active in order for them to work in the body to create a thrombus. So if the liver is compromised or is being damaged, like in hepatitis, cirrhosis, hep C, all these things, then these patients are at greater risk of having risk of bleeding. And so you just want to be able to assess that, especially at baseline and intermittently thereafter. That's why that is listed there, so that you understand it, okay? Now, patients with obesity. We have this problem in our country, unfortunately. This is not with just this drug class, this is with other drug classes as well. The appropriate dose to achieve the therapeutic benefit at the site of action in some of these patients. A lot of these patients are not always included in the clinical trials. And so the safety and efficacy of them is not necessarily known if you practice more in a purist perspective of evidence-based medicine and clinical practice, right? Patients who weigh more than 120 kilos have not been adequately prospectively studied, okay, so that you have strong definitive recommendations. But they've done subgroup analysis, which we all know has its limitations in evidence-based medicine, but it's better than no information, right? It can guide us a little bit, right? And they've suggested that Apixaban and Rivaroxaban, that those patients can maintain some degree of efficacy and safety compared to warfarin up to 150 kilograms. Now, properly calibrated anti-10A monitoring assay, assuming you even have access to that, okay, can sometimes guide you in these patients with obesity. But again, it's not definitive. I just wanted to make you aware of those limitations so that when you have a unique patient scenario, don't make the assumption that you can extrapolate all the information across all patients. Apixaban may be a little bit more preferred in our geriatric patients simply for a smaller risk of bleeding and GI bleeds. Pediatric patients, Rivaroxaban may be used in patients up from infants through 12 years for prophylaxis and Fontan procedures for congenital heart disease, patients with VTE or recurrent risk of VTE from a hypercoagulable disorder. Okay, so as we wrap things up, remember the classic agents, Apixaban, Edoxaban, Rivaroxaban, they make up our oral anticoagulants, DOACs for factor Xa. The IV or parenteral, IV, the sub-Q parenteral formulation, Fondaparinux, is unique. Indications, atrial fibrillation, prevention of cardioembolic stroke, VTE, okay? Mechanisms, remember they prevent that conversion of thrombin, prothrombin and thrombin because they're directly and selectively inhibiting that Xa. Okay, that's really important. Side effects, obviously bleeding. Okay, that makes sense. From a couple clinical pearls, remember they have a short onset of action. They get it there pretty quickly compared to things like Warfarin. So that gives us the opportunity to discharge patients home, assuming they can get the medications, assuming they're going to be compliant with the medications, because remember it's less forgiving. Okay, so they have shorter half-lives compared to other options. So we need that compliance and adherence. There are also risks of drug interactions that can happen. Don't forget about that cytochrome P450, 3A4, P-glycoprotein. And then lastly, don't forget about our renal function and reversal. We don't have the reversal agent Andexanet Alfa anymore, so we just use PCC if we need to reverse these patients. Okay guys, I hope you found this information to be helpful. Please subscribe to us on YouTube and check us out at thisiswhy.health. Please give us a like. We really appreciate that and value that, your feedback and input. I'm Dr. Busti and I really appreciate you guys joining. Please, please guys, never stop learning the why because it makes the how so much easier and you can do more for your patients. All right, take care. We'll see you next time.